Welcome everyone to Concurrent session number 12, Security and Disaster Safety. My name is Dawn Potter. I lead the Canadian healthcare team at SailPoint Technologies. SailPoint's thrilled to be sponsoring eHealth 2022 and bringing you this session today. For those of you not familiar with SailPoint, we are a cybersecurity technology company, and we bring identity and data governance solutions to hospitals and health systems across the globe, many of those right here in Canada. So please feel free to visit our booth if you haven't already, and connect with us if you'd like to discuss your organization's identity security program. So this session will include two 15-minute presentations. If you have any questions or comments for our speakers, please type them directly into the Zoom chat, and our speakers will address them immediately following their talks. You're also encouraged to connect with the speakers after the session through the virtual event platform. So without further ado, I'd like to welcome to the virtual stage our first presenter, Ariane Siegel, General Counsel and Chief Privacy Officer at OntarioMD. Welcome, Ariane.
Thank you very much. Good morning, everyone. And in my presentation today, we're going to talk about virtual care as a defense against the dark web. And what I hope to speak with you about are issues related to the critical importance of privacy and security, the role of training and education, a little bit about OntarioMD's training programs that we've put in place over the last few years, some privacy and security best practices, and lessons learned for future training, and all this in less than 10 minutes. So let's start with the critical importance of privacy and virtual care. Healthcare professionals, as you are aware, are subject to regulation regarding the collection, use, and disclosure of personal health information. Those requirements have become more complex and overlapping over the last number of years. We know that privacy is key to public trust in the healthcare system, and most of all, patients value their relationship with their healthcare providers directly. Against that backdrop, cyber attacks are on the rise. In June 2021, Humber River Hospital was hit by an attack. In November of 2021, the government of Newfoundland faced an attack on its provincial healthcare network. Most recently in Ontario, Arnprior faced a number of security incidents related to the hospital and healthcare providers in that setting. Our community's cybersecurity establishment has been warning against the increased threat of cybersecurity as a result of the Russia-Ukraine crisis. Training and education can play a critical role in helping to safeguard our healthcare networks. Most security incidents are the result of human error, which are the weakest link in the protections that we've set up against our healthcare system. All systems are vulnerable to social engineering attacks, and defensive use behaviors are the best protection against many of these threats. An effective detection and response system requiring stronger user comprehension of privacy, confidentiality, and procedures is key. Training is key. Methods must be user-friendly and intuitive to encourage positive habits. So my lessons learned today are really training has to be easy to understand, and it has to be practical. In responding to the increased threats and the need for more privacy and security education in the healthcare community setting, OntarioMD began in 2017 by instituting the first of its kind privacy and security online training for community healthcare providers. In 2021, we were very fortunate to support the Ontario Medical Association in its partnership with Canada Health Infoway in developing online privacy and security training with respect to virtual care. This was a process instituted over a 6-month period. From March to July, we engaged with a broad number of stakeholders in order to consult with them to determine the key knowledge gaps and needs with respect to privacy and security in the virtual care setting. We quickly developed complementary software hosted via web portal and put our privacy and security training module on that portal. The privacy and security module for virtual care is now available online 24/7. It is auditable and it issues a certificate as well as CME credits. The key topics include cyber and security best practices and considerations for virtual care and college requirements and policies, as well as information about consent and templates that are accessible to the user. The module contains an opportunity for feedback. When we talk about privacy and cybersecurity best practices, as I've indicated, we've tried to make it practical. And to that end, we've really grouped our training to support 3 key themes. 1, governance and training. 2, static tools and safeguards. And 3, good privacy habits. And so if we look at these 3 areas, really they're key lessons learned. Under governance and training, it's critical that networks and clinics have governance agreements in place, that there's annual privacy training to support those practices, not just the healthcare providers, but their support staff who are critical to the interaction process. They need to have privacy policies in place. There should be an incident response plan, and there should be considerations with respect to cyber liability insurance. With respect to practical static tools and safeguards, they include the use of verified virtual visit solutions in the province of Ontario. Important tips like backing up contacts and data, multi-factor authentication, encryption, and updating of software and hardware. With respect to privacy habits, passwords are key. Basic tools like auditing logs, and tips for the user to ensure they think before they click. Passwords are critical and have become ever complex. We need better systems to manage our passwords, and we need a better approach. To that end, Apple, Google, and Microsoft have recently announced that their plan is to work together to get rid of passwords. But that plan is not today or tomorrow. It's a bit off. And so for the time being, we're going to have to find better systems to manage our passwords. There are important lessons learned. First of all, numbers tell a story. It took us 6 months to set up, develop, and launch our online privacy and security training module for virtual care. We supplemented that online module with webinars and training. Those webinars and training have been viewed across Canada and in 21 international jurisdictions. Lessons learned. Training has to be practical and it has to be implementable. It needs to use plain language. You need to have feedback from diverse stakeholders. And my approach has always been to listen to the stakeholders and to run my drafts by them. I find that if everyone's not satisfied perfectly, if everyone's just a little bit mad at me, then I found the right balance and I've satisfied as many needs as possible without perfecting it. It's important to know your client. OntarioMD, we support community care providers, meaning family doctors and specialists. We understand their issues and can really help to bring the system together by bringing that perspective to the table. It's important to revisit your key concepts and your assumptions regularly. And it's important to make a tool that's auditable and to provide your audience or your users with credits. So those are my lessons learned, and I'm happy to take your questions. Thanks so much.
Thank you, Ariane. And hopefully these measures and tools are something our audience can start to implement in their organizations. I don't see that we have any questions in on the chat yet. If there's anybody that has a question for Ariane around privacy and security in your organization, feel free to enter a question into the chat and we'll get back to you. As a reminder as well, you're also able to reach out to the speakers through the virtual platform after the event. Okay, well, if there's no questions, then we will look to Kim and Brad to tell us about the disaster communication system. So we have Kim Jessen, registered nurse and clinical information specialist, and Dr. Brad Granberg, emergency medicine and disaster medicine specialist. Kim and Brad, over to you.
Hey everyone, I'm Brad Granberg. As mentioned, I'm a physician at AHS. I think we're just going to share our slides here. Is that right? Here we go. So I'm Brad Granberg. Kim Jessen, as we mentioned, is along with me, and we're going to be kind of tag teaming this presentation. So we're really excited. This has been a piece of work that we've been on for about 5 years, and it really launched right during COVID. So we're here to talk about the hospital-based disaster communication system. So Kim, go ahead.
Sorry, having a little
Able to
trouble
advance
with
the
the
slides?
Not yet.
Oh, we don't have control yet. Is Anthony able to give us control? Okay, there we go. So just to declare, so conflicts of interest, both Kim and I work for AHS. However, we do also own a tech company, TechEd Integrated Systems. We hold the rights to DCS, and we also do work on another of other applications, specifically around EMS, ED, and inpatient overcrowding. So a lot of what we do is developing technology to try to help balance the system and try to improve the system. Go ahead. So what we're talking about here in this presentation is really the hospital disaster preparedness. Most of you have heard a lot about this over COVID. And really, for those of you who don't know anything about it, excuse me, what we're talking about is the disaster surge capacity. So we look at 4 S's. This is kind of the typical teaching, is that we look at the space, the ability to handle this surge of patients that are coming in. These are our hospitals, our waiting rooms, anything that we can use. The stuff is our equipment that we try to gather as we're trying to go through this surge capacity. The systems are the things that we put in place, our incident command systems, our technology, and different applications that we use to try to improve the coordination during a disaster. And really the staffing is the part we're going to talk about today, is how do we bring in all of these people in a coordinated manner to the right place at the right time. Go ahead. And so in 2016, we actually did a simulation. This was a citywide Code Orange, which is a disaster simulation for Calgary. And what Kim and I looked at was we looked at specifically the staff search protocol for physicians. We looked at what type of search protocol we had, the time to call physicians out, the MD response and availability, and really were people able to get in? Was the site ready to respond to a disaster? What we found was it took 1 to 2 of our unit clerks almost 2 hours on the phone. And they basically pulled out a list and started calling by phone each physician one by one, getting an answering machine and leaving a message. We only had 6 responses at the time, and less than 1% of people were available. We actually failed this, and we failed it horribly. And I think this was a wake-up call, not only for our system, but for the rest of the country. If we weren't able to bring people in, how are we able to respond to any of the disasters that we were seeing? So go ahead. So what we did was we undertook a study, and we looked across Canada to see what other hospitals were doing. And we found that a majority of Canadian hospitals were actually using the same system we were. They were using a phone list where they would try to call physicians in at the moment and see if they could bring them in. We found that 30% actually had no plan at all. And even fewer hospitals and fewer emerges basically had come up with something on their own. And they started to look at third-party messenger apps like WhatsApp. And they had a group where they would just text out that they'd had a need for a surge. As pointed out in the previous presentations, these have inherent security and reliability issues. WhatsApp is not designed as a disaster application, and it shouldn't be relied on in the middle of a crisis in a city. So we set forth to develop basically a novel communication system for hospitals and emergency departments. And Kim, I'll turn that over to you.
Sure. So we don't actually have time to do a demo. So I'll let you just read the slide here and take this opportunity to explain how the system works. If you'd like to see something afterwards, please just reach out. So when a code orange is declared, a staff member, usually a clerk, will log into the DCS dashboard. A single click will send a text message with an availability survey out to all the physicians, staff, nurses, etc. You'll see an example of that survey on the screen there. Staff then respond to the text survey on their phone, and responses are then summarized and displayed on the dashboard. It's all very pretty, color-coded, and available staff filter to the top of the screen. The unit clerk will then call in the number of staff required by clicking an icon beside each person's name. And then another text message will then go out to the staff member to come in, report to the unit clerk, and then acknowledge that they've received the request. So that sort of completes the communication loop. When the staff member arrives and the clerk sees the whites of their eyes, they can indicate on the dashboard that the staff member has arrived. So all of this information, as I've said, is visible on the dashboard. So staff, admin can easily see how the fan out is going. And the information is then all date and time stamped and stored for post-event analysis. And Brad, I guess I'll just leave this to you to show the results of the testing that we've done over the last couple of years.
Yeah, sounds good. So as we said, we implemented this right when COVID came out, which was a bit unfortunate. But you can see we've summarized a lot of our data. So the initial phone system is there on the left. When we started doing DCS, we implemented it in all Calgary area hospitals. And since then, it's actually caught on, and we've expanded into the southern zone and even to different groups. So what we found with our results was with the DCS is that the unit clerks took less than 10 minutes. And in fact, this is less than 30 seconds. They basically, as Kim pointed out, click a button and the system works itself. 100% of the physicians were contacted in less than a minute. We had a 48% response rate and 22% availability. So really what it shows was DCS took a system that was not working at all, and we actually brought it to a point, and it's a very simple system, but we brought it to a point where we could actually function quite well. And so we considered this a pass. When we looked at the amount of physicians we needed, the amount of nurses we needed, as you see in the South Zone, we were able to bring in people immediately. We were able to coordinate both physicians and nurses to bring them into different hospitals as needed and move them around quite efficiently with minimal work. So we considered, we were quite surprised initially with our first results. And again, it's been replicated over the years as we continue to test and we continue to expand into different zones. And as you can see on your chart, so we were quite happy with, I guess, the results. Go ahead, next slide. So what does this mean? Really, the disaster communication systems, it really streamlined our process. It took a unit clerk's work time down to almost nothing. It enhanced our response times for all our physicians. And the interesting part about this is you can imagine that when we implement this in COVID, everything was a bit in flux, and we actually were able to, I guess I would say, maneuver the system to do other things. Initially, we found that we weren't in a surge capacity in COVID. We needed to bring in managers and bring them together. So we actually, I would say, hacked the system a little bit and changed it so that we could bring in managers to have meetings, to have these critical meetings early on, to bring in IT people. And really, you know, it says disaster communication system, but at its core, this is a communication system, a secure communication system that can do multiple different things. We had significant person and time cost efficiencies. It is a confidential and secure system that sits on the HS servers, and really it enhances patient safety. We started to look at, as we mentioned, as we started to get more and more people interested, we started to notice that not only was it the ER and as well as ED staff, but we also noticed nursing wanted this application. We've had interest from trauma, from cardiology to deal with heart attacks, stroke protocols. A lot of the allied health services, EMS, RTs, hospital admin, as we printed out before, were interested in a secure communication system that was able to coordinate and bring people in times of stress or crisis or emergencies. As we said, we begin to expand within Alberta and Southern Alberta, and we continue to work towards moving it in Northern Alberta. And we've even started to look at applications for utilities and telecoms, police, fire, wildfire services during disasters. I was part of the response that went to Fort McMurray during the fires, and we noted we had a significant lack of communication. As always in all disasters, it seems to be the #1 issue, is the lack of communication. So next slide. So really that's us. That was a very brief, usually what we like to do is give people a demo. It requires very little. As long as we have your phone number, we can get you information. The survey's filled out and we will know exactly what your availability is, what your priority is. And the system just coordinates, communicates, and deploys people to the right place at the right time. So that's it for us. If we have any questions, I'll hand it back over. Thank you.
Thank you.
Thank you, Kim and Brad. Fantastic work on the DCS initiative. We do have a few questions that have come in for our speakers, so we'll work on tackling those. Ariane, I believe these ones were addressed to you. The first being, are password managers safe to use? And I have my own strong feelings on this, but I will reserve answers for you. I believe a passwordless system is definitely the best if you can implement it. But what are your thoughts on password managers?
Yeah, and I think everyone has their own preferences. The problem with storing passwords in your notes, for example, on your phone, is that if there's a problem with your phone, you lose your phone, or in fact, even if your phone account gets diverted, as has happened to some doctors, your account can be diverted, then you're going to have a problem. And so that's not necessarily a recommended approach. There are password management systems that people have used. And each one varies and really is based on personal preference and accessibility. I think the second question that came in was related to, is privacy and security training mandatory, or is OntarioMD's privacy and security training mandatory? And so the Privacy Commissioner in Ontario has indicated that healthcare providers are expected, absolutely must do privacy and security training. And that would be one of their key responsibilities or accountabilities, and they must require their staff to do training. There is no training that has been identified as the standard or one that's specifically required. There are various training modules that are available. Some hospitals, for example, require their training to be used. OntarioMD has specifically tailored its training to community care providers. And our next phase, and so it's probably extremely relevant to anybody working in the community setting. Our next phase, we're actually creating a module now that is going to be implemented in one part of the province that all healthcare providers, whether they're hospital-based or community-based, are going to use. And I think that will be the model that becomes most functional and most usable. So that's my response to those two questions. Any other questions from me in particular?
That's all that we've had come in through the chat, but attendees are welcome again to reach out to Ariane or Ken or Kim or Brad directly through the platform afterwards if questions come up. I think we had a comment from Ben around the DCS system. Great idea. It's you know, archaic that telephone fan outs are still being maintained, and yeah, that's more the norm than the exception for sure.
Yeah, I agree. I mean, I think we were quite surprised. I think when we did the study, we weren't aware of what was going on across Canada, and so I think that was probably the push to get us developing.
Yeah, and I would just add that we have tested this in 8 hospitals now, and the response has just been overwhelmingly positive that they don't have to use the phone anymore, and the system is just so intuitive and simple. So thank you for those comments.
All right. Well, if we don't have any other questions, again, you can reach out to the panelists through the virtual event platform. I'd now like to invite all attendees to join our exhibitors for networking and discussions in the virtual trade show accessed at the top of your screen. We hope to see you there. So thank you, everybody, for your time today.